What's up, Ninja Nerds? In this video today, we're going to be talking about peripheral artery disease. Super quick one, let's blast through it. When we talk about peripheral artery disease, we're talking about disease of particularly the vessels of more likely the lower extremities, less common of the upper extremities. So we're talking about those vessels like the aorta, the iliac, we're talking about the femoral, the popliteals, all the way down to the tibial ulnar vessels. There's something that's diseased within these vessels, and there's a reduction of blood flow to the tissues within those extremities. What can happen if we don't provide an adequate perfusion to those tissues? Think about it. You have a big old plaque within this vessel, right? Blood is supposed to be able to move down this vessel, and as it moves down, it has to run through this little narrow area. That means all of the actual tissues past that thrombotic area are susceptible to what? Susceptible to less oxygen being delivered to it, less nutrients being delivered to it. If there's less oxygen being delivered to the tissues in the area, like the muscles, the skin, etc., what's going to happen? If I don't give oxygen to my tissues there, they're going to start to experience ischemia. Less oxygen delivery can lead to the actual tissue starting to suffer from a decrease in oxygen nutrients. What happens is the ischemia, if not fixed and severe, so for an increasing amount of time and it's not fixed, this can lead to the death of the tissue, infarction of the tissue. That's a scary thing. But you know what else can happen? With ischemia, if you have ischemia, and let's say that you really increase your exertional activity, you start walking, you start running, you start utilizing those muscles, what happens then to the muscles? The muscles start increasing their O2 demand. Now think about this, my friends. Having decreased oxygen supply and an increase in O2 demand, that's a severe mismatch right there. And what's going to happen to the ischemia now? The ischemia will increase even more, causing more complications, potentially progressing to infarction if not fixed or over a long period of time. So that's the basic kind of pathophysiology of peripheral artery disease. Now the question is what's causing this reduction in oxygen supply? Let's talk about that now. All right, so what are the reasons for actually developing this reduction in oxygen supply? Well, the basic concept is you have thrombosis or you have an embolus, right? Now, a thrombosis of the actual vessel is usually going to be more of a chronic type of issue for peripheral artery disease. So it'll be more gradual, be more progressive. Whereas an embolic type of problem, this is more acute, it's more sudden. So a patient develops a lot of complications and features that we'll talk about in a little bit very acutely. If it's more chronic, slow, progressive, it's more likely thrombotic. So think about that in your clinical vignette. What are the reasons for thrombotic causes and what are the reasons for embolic causes? The thrombotic, most common by far, please for the love of goodness don't forget this, is atherosclerosis. What are the factors that increase risk of atherosclerosis, my friends? So think about a patient who has hypertension. Think about a patient who has high LDL or low HDL. Think about a patient who is a smoker. Think about a patient who is a diabetic. Think about a patient who is old, so old age. A lot of these factors are very important for the prediction and risk of developing plaques within the vessel wall. And if you have a plaque within the vessel wall, look at that, my friends, there is a reduction in oxygen supply and therefore peripheral artery disease. Now, the other thing is you could have known factor of thrombosis and plaques and you've been treated for it. You have a stent, but guess what? The stent got all thrombosed because you didn't stay compliant with maybe your medications that you're supposed to be taking for it. So sometimes you can get what's called a stent thrombosis because of a failed compliance. You know what you're supposed to generally be taking when you're on you get a stent placed? Generally, you're supposed to be taking things like aspirin and Plavix for the first year, and Plavix is clopidogrel. So you're supposed to do that for at least 1 year and then switch over to just one of them, aspirin. Let's say that you don't do that within the first year, you're not staying compliant with it, you have a high risk of thrombosing that actual stent. So that's important for the thrombotic causes. Embolic causes, pretty straightforward, my friends. You have in some type of terrible situation here, you have a big old clot within inside of the atria, and you decide to pop that clot off of the atria, it flies up through the aorta, down the aorta and gets stuck maybe in the aorta iliac area. And now you're not going to be perfusing the tissues beyond that area. That's going to cause a severe ischemia, potentially infarction. What would be the diseases that would pop off of that? Atrial fibrillation. What if I had another one that popped off of the left ventricle, right? You're like a left ventricular thrombus. So patients who can develop left ventricular thrombus, this could be due to an MI. So post-MI, it could be due to left heart failure. A lot of different reasons for that, right? The other situation is maybe it's not from the heart, maybe it's more downstream that you develop these actual clots and then they break off pieces. You know someone has a AAA, abdominal aortic aneurysm, In these situations, they have this dilated area that allows for turbulence of blood flow, and that can allow for stasis of blood flow as well. So blood can actually stay a little bit in this area and you can form a clot. And if I break off a piece of that clot and that sucker flies down and gets stuck in one of the actual vessels here, occludes this vessel off here, boom, decreased oxygen to nutrient supply distal to that. That could be one reason. The other one is if you develop a popliteal aneurysm. So you know patients who get popliteal aneurysms, this is another one to be thinking about. In this situation, again, you have this aneurysmal dilation, you can form a clot within this area and then break a piece of that off, have it get stuck in the vessel, reduce the oxygen nutrient supply, boom, you end up with peripheral artery disease. The other things to think about if you really want to add them on is like if you have a lot of inflammation of the vessels, like a vasculitis, or you have trauma, where you end up having a lot of compression of the vessels. So sometimes people get like what's called a compartment syndrome. So think about those. Those are more of the acute things that we'll talk about a little bit later. But let's talk about features and complications. If you have plaques or clots or whatever it may be, whether it's a thrombus or embolus within the vessels and you're reducing the blood flow to the tissues, one of the big things is the muscles really start to, not get enough kind of oxygen, nutrients, and they can cause a lot of pain. And this pain is actually very important to delineate. All right, so there's 3 types of limb pain or peripheral artery disease pain that we have to be able to understand because it determines the severity and how quick we need to intervene. So if a patient says that they have pain, and where is this pain? That's the actual first thing that we should understand. The pain location tells us potentially which vessel may be plaqued up or occluded. So think about that. If you have a plaque or embolus within inside of the aorta or the iliac or around the branch area, what could be the potential issues? Well, you're not going to give oxygen supply to the hips, the buttocks in that area. And so in these patients, they typically will have hip and maybe even some buttock pain. The other thing is it goes down to your entire extremity. So the pulses, your popliteal, your femoral, your pedal pulses, they'll all be diminished. And so they'll have decreased pulses. The other thing, it's also supposed to go to the genitalia. Blood flow to the genitalia will be also affected. And so in this situation, you can also experience sometimes erectile dysfunction. Now, femoral popliteal, so in that area, it's supposed to go down to the actual, get stuck around like the thigh area. So you're not going to get blood flow to the calves. And so this can actually cause calf pain. And then the last one is tibio-ulnar. These are supposed to go, just get stuck within the calves. And so because of that, if you have plaque developing in the calves, you're not going to get blood flow to the foot. And so this can cause a lot of foot pain. So if the patient has any of these pains, that's kind of the claudication pain. It's pain that is really going to be due to a vascular issue. And what's important to understand is what actually exacerbates this pain, and that's really, really key. So if the pain is worse whenever they're exerting themselves, why would that happen? Because if you exert yourself, what are you doing to the oxygen demand? You're increasing the O2 demand. And you already have a reduced O2 supply in these atherosclerotic or embolic cases. If that's the case and you have a combination of these two, this may lead to enough ischemia to produce pain. And so what we have to remember is, in situations like intermittent claudication, whenever the pain is worse with exerting themselves, it's because they have an increase in demand. If they rest, their demand drops, it could actually improve and their pain is not as bad. So remember, if it's worse with exertion, it's because there's an increase in demand. And if it improves with rest, that means the supply is still enough. It's suboptimal, but it's enough to be able to get enough oxygen to the tissues for them to be able to at least somewhat function. But if we exert ourselves, the demand goes up, the supply is not enough, and we experience ischemia. Now, if the pain occurs at rest, that means the supply is super, super low. That means that you have a very, very low O2 supply. And it doesn't matter a dang if you have an increase in O2 demand. That'll make it super worse, but your supply is super low, that you're having ischemic pain to the actual legs or hips or buttocks or feet in situations where you're at rest. Now, there's something called Buerger's sign. So Buerger's sign is very interesting, and it's changing the color of the legs in specific positions. And what are those positions that you actually would want to remember? If you have the patient elevate their legs, okay, they're having to work the actual blood flow against gravity. That's going to cause the color of the extremities to become worse and the pain to become worse. So the pain worsens and the color will actually get more pale. And so because of that, that would be a sign in resting claudication. Now, if it improves when their legs are hanging, because now the blood is actually be able to moving with gravity in that situation, the color will improve. They'll have more redness, more good pinkish hue to the actual extremity, and the pain will be somewhat reduced. That is, again, a sign of resting claudication. Now, the scary one is if they have critical limb ischemia. So their limb is actually threatened because there's so much decreased supply that the limb is literally at risk of potentially becoming infarcted. And if the rest pain is greater than 2 weeks, that's one indication you have critical limb ischemia. If you have arterial ulcers, that is an indication of critical limb ischemia. And if you have any evidence of gangrene, that is an evidence of critical limb ischemia. If you have one of the following, you have critical limb ischemia, and there is a severe reduction in oxygen supply where the tissue is at risk of infarcting and it is beginning to infarct. So that is the big things to remember for this disease. Okay, we got the pains based upon location. We got what the actual pain based upon exertion or rest. At rest, maybe changing with position, or if they have any of these findings of critical limb ischemia. Now, what are the other features that we have to talk about? The other thing is pretty straightforward. If you have a big plaque or you have an embolus and it's occluding the blood flow through this area, think about what's going to happen to the pulse that you're going to be able to palpate distal to that area. What's going to happen to it? You can have reduction or sometimes absent pulses in this disease. If it's absent, it's super scary. The other thing is you have a lot of turbulence of blood flow in this area. And if there's lots of turbulence of blood flow due to this plaque, what's that going to do? It's going to increase the actual bruits that you'll be able to auscultate. So those are big things. The other thing is, think about this. Your muscles are depending upon oxygen to be able to make ATP, to power those pumps, to be able to allow for contraction. If you have less oxygen, the ATP production goes down and the muscles won't be able to work as well. And so because they're not working, they actually can potentially atrophy. And so it's one of the other things with the muscles that you could start to see some atrophy of the muscles. And that's a concerning sign. So again, think about these particular things here, guys. All right, the next thing that I want us to talk about here, besides the atrophy of the muscles, besides the decreased pulses and bruits, besides the particular pain and the types of pain that we can have here, is some of the skin findings, and then worst case scenario, what happens if we actually don't have any blood flow to the extremity? What are some concerning signs of acute limb ischemia? Let's talk about that. All right, so what are some of the particular things that you want to remember? So we understand that if you're not getting enough supply to the muscles, we obviously can develop the pains, we can develop atrophy. If you're not getting enough blood flow to the actual distal part of the artery, you can have decreased pulses, turbulence of blood flow with the bruits. But if you're not supplying the skin enough oxygen, what can happen there? So the big thing is that it is a progression of the disease. So first thing is, if you're not getting enough oxygen to the actual skin, it can start to actually cause the color of the skin to decrease, so it can actually have like a pale color to it, and the temperature. Blood carries with it a good temperature. It actually almost about 38 degrees Celsius. So if you carry a lot of blood, you actually have warm skin. But if you have less blood flow, it's gonna be a colder type of skin. So decreased color, and then it's also gonna be a very cold extremity. So you're gonna have decreased color, and it's also gonna be cold. The other thing here is that you actually supply a lot of oxygen to the actual hair. And so hair growth is also dependent upon oxygen and nutrient supply. If you actually have a decreased oxygen and nutrient supply, you can have decreased amount of hair. So there can be hair loss. There can also be thin skin. So the skin actually starts to get really thin because you're not supplying the actual tissues to continue to keep replicating. And the nails are actually part of your skin. So the nails get really thin as well. So look for decreased color, so pallor, cold extremities, decreased amount of hair, thin skin, thin nails. The next thing is if you start to see arterial ulcers. These are important because they look punched out, they're dry, and they usually, one of the big things for arterial ulcers in comparison to venous ulcers is that they're over pressure points. So usually this is over the toes, over the lateral malleolus. So think about that. These are punched out, they're dry, and they are usually, in these situations, over pressure points. Okay, the other thing is if this progresses where the oxygen supply to the tissue becomes even worse, where the arterial ulcers actually progress, or maybe on top of this, you just don't supply enough oxygen to the tissues where the actual skin starts to die completely. Then you can start seeing something called gangrene. So there's two types of gangrene. The first one is there's not a lot of like moist, in situations like here, that's not like super moist or exudative and not a lot of erythema, is usually just a lot of black discoloration of the skin, unfortunately. And this is called dry gangrene. If it progresses to where you get a lot of erythema, you get a lot of infection, a lot of exudative material, and black discoloration, and we're worried about it being infected, then we're talking about wet gangrene. And wet gangrene is scary because this can potentially progress to a septic type of nature. So this is the skin findings that you need to be able to remember. And as you go down this list, the actual skin manifestations getting more severe, that's the more severe type of peripheral artery disease. Okay, so decreased color, cold extremities, less hair, thin skin, thin nails, progressing to arterial ulcers, to dry gangrene, to wet gangrene. Now, the last situation here that you have to remember as a potential complication in this disease is acute limb ischemia. Now, acute limb ischemia could be due to a thrombus. It could be due to, less commonly will you have this, and this is basically where a patient develops an acute occlusion of the blood vessel, and there's almost no blood flow, where they have these particular types of clinical features called the 6 Ps that we'll talk about. A thrombus, less common. Embolus is going to by far be the most common type. Like 80 to 85% of the time it's that. The other thing is it could be due to compression. So compression of the blood vessel, and this could be due to like trauma. So sometimes if you like fracture a bone, or you have a lot of like what's called compartment syndrome, that can actually compress onto the vessel as well and reduce the blood flow. But by far the most common is going to be an embolus. Now, if you severely reduce the blood flow super quickly to the actual tissues, you have no oxygen, severe ischemia, quickly doesn't actually fix, and it becomes to the point where you infarct the tissue. What could this look like? Where it actually starts to begin to progress to this. First thing is the pain is super out of proportion. The other thing on top of that is you can actually cause the muscles to start becoming destroyed and actually infarct, and you lose muscle strength. And so you start to actually see weakness, or even worst case, paralysis. The other thing is if the skin is not being supplied, on top of that, you can have what's called severe pallor. You're not giving enough blood supply to the actual skin, so pallor. On top of that, it's also supposed to be able to regulate, the other thing is skin temperature. So what did I say? If it's decreased color and cold, it can't regulate that, so it's called poikilotherma. And the other one is if you actually have nerve fibers that are within this area that are supposed to be able to pick up sensations. And if there's actually destruction of that, you potentially can have paresthesias. And the last situation here is if you have literally no blood flow that's being able to get past this area of the embolus, what's going to happen to you being able to palpate the pulse distal to where that embolus is or thrombus is? They're going to be pulseless. So this is called the 6 Ps in this situation here, where they have pain out of proportion, paralysis, pallor, poikilotherma, paresthesias, and pulselessness. If you see this, it is very concerning for acute limb ischemia, and most likely the most common cause of this is an embolus, maybe from atrial fibrillation, a left ventricular thrombus, a AAA, or a popliteal aneurysm that popped off an emboli. Now the question that you have to be able to answer here is, what is the actual level of acute limb ischemia? Is it a point where I can still save the limb? Is the limb threatened, or is there no point in me even saving the limb? They're just going to need an amputation at this point. So that's depending upon these very specific things. So weakness. If there is no weakness, that's a good sign. That means that we haven't actually infarcted the muscle yet. If the pain is like minimal, that's a good sign. That means that we haven't infarcted the tissue yet. If the sensory loss is actually going to be pretty much none, that's a good sign. And if we have positive Doppler pulses, that's a good sign. That means that the limb is actually okay, and we can go ahead and potentially revascularize this. Threatened, we need to revascularize this immediately, because if we don't, there's a potentially they could lose that limb. So weakness, it's getting pretty bad, okay? Pain is getting bad. The sensory loss is actually starting to get bad. And the Doppler is either absent or reduced. If that's the case, you should probably go ahead and get them revascularized as soon as possible. Weakness, if they are paralyzed. If there is paralysis, it's too late. The tissue's infarcted. If the pain, if there is no pain, that means that you've completely destroyed all of the nerve endings, and it's completely infarcted. There's no chance that you're even going to be able to save that limb. Sensory loss, if this situation here, they have, again, loss of sensations, that's a concerning sign. And then lastly, if there's absent pulses, again, that's a concerning sign, and there's no chance of being able to save that limb. That acute limb ischemia has now completely caused the infarction of the limb. So it's important to be able to understand these features, these complications. Now that we've talked about this, let's go over the diagnosis. All right, so let's talk about the diagnosis of peripheral artery disease. So the first line test that we're going to utilize here is going to be an ABI, ankle brachial index. And this is generally going to be your first line for peripheral artery disease. Not so much in the critical limb ischemia or acute limb ischemias, but more of like the non-acute types of peripheral artery disease, the ones with intermittent claudication or resting pain, etc. So in this situation, what we do is we take the blood pressure on the ankle and we take the blood pressure on the brachial artery. And all we're looking for is what? Think about it. Usually the lower extremities are the more commonly affected. So if I think about the pressure that's actually going to be going to this ankle, like this actual ankle cuff, think about the pressure that's going to be getting and actually being detected by the actual ankle cuff because of this big old plaque within the actual vessel there. It's going to be super reduced, right? Because I have a plaque that's reducing or limiting the blood flow to that actual lower extremity. So the ankle systolic blood pressure should be low, and then a brachial systolic blood pressure, we shouldn't have many plaques within the upper extremity vessels, so that should be relatively normal. So think about what that would do to the ABI if you had someone who had peripheral artery disease. Think about it, super straightforward. The lower the numerator, what's going to happen to the overall ABI? It should be lower. So the lower the ABI, the more severe the peripheral artery disease. So what's the actual number that we need to remember? Less than or equal to 0.9 is diagnostic of peripheral artery disease. And as you go lower and lower and lower, the more severe it is. Like less than 0.4 is pretty bad. Okay, so that means that generally we're like borderline if we're like 0.9 to 0.99. That's more like borderline PAD. And then it's relatively normal if you're from like 1 to 1.4. And then last situation here, sometimes this can produce like a weird one. It's usually due to non-compressible vasculature and like patients who are older and have super calcified vessels. Just remember that you can get something called medial calcific sclerosis when it's greater than 1.4. So this is called medial calcific sclerosis. And this is usually due to like a non-compressible vascular wall. Sometimes that can produce kind of this really high number. But generally, this is how we actually go about diagnosing PAD. We see less than or equal to 0.9, PAD. The lower it is, the more severe it is. That's it. With the next test here we got to talk about is your CTA MRA, okay? Next one is the duplex ultrasound, and then we'll also talk about something called digital subtraction angiography. Let's get into that. All right, so the next test, we do the ABI, right? That's the first line test. Sometimes you can do further tests if you really need to. So a CTA MRA is basically going to be a really cool thing where it can push contrast into the vessels and light the vessels up. And that's really important if you have a patient who has like an acute limb ischemia, or they have like some type of critical limb ischemia, or like a non-acute PAD who is their PAD is super low, and you're trying to determine if this patient is a good candidate for revascularization. So this is really a good one. I think that one of the benefits of this test is that you have plans to go ahead and revascularize the vessel, and you want to get a really good look at the vessel and where it's all plaqued up. So that's one of the benefits of a CTA or MRA, is because you shoot some contrast into those vessels, light them up, and you can see the length of the vessel, where it's all plaqued up, and where you want to actually target and how you're going to target it. Okay, so that's good for your acute limb ischemias, your critical limb ischemias, okay, patients with PAD who have very severe, like very bad ABIs. The duplex ultrasound is actually kind of a cool test. It's a good bedside test, so it's actually not a lot of like, things that are going to be requiring a lot of like people. It's a very simple alternative test to your classic like CTA MRA. So you can use this as an alternative to the CTA MRA. It's pretty good, it's bedside, and the primary reason you would do as an alternative is if you have a contraindication to like contrast. And it's pretty straightforward. You actually take the duplex ultrasound and you'll be able to see the actual occlusion. And what happens is you have these high velocities through the actual vessel because of a significant stenosis of the vessel. And that's usually due to a plaque or an embolus. So that's the duplex ultrasound. The last test here, which is actually kind of like your gold standard, it would be the most definitive diagnostic test, but it is crazy invasive, is a digital subtraction angiography. All you do is you take a catheter and you shoot contrast in real time around the actual vessel, and you'll be able to see the contrast filling up the vessels and seeing where there's a lot of stenosis, and that'll be able to show you, oh, there's a critical stenosis at that point of the actual extremity. So boom, that's what we would use for that test. So if you were to ask in the exam, which test is the first line test, you would say ABI. Which one is good for revascularization plans? CTA MRA. If you have a contraindication to a CTA MRA, you can do a duplex ultrasound. And then last, what is the gold standard, but it's super invasive, it's a digital subtraction angiography. Done. The next question that you may be asked is differentiating neurogenic claudication from vascular claudication from PAD. So neurogenic claudication is usually due to something like a lumbar, like spinal stenosis. And a patient who has spinal stenosis, they can have compression of their spinal cord or compression of the actual nerve roots. And so sometimes that can produce similar types of pains, especially if it's compressing the nerves that are going to their lower extremities, their calves. And so they may have calf pain, and it may actually hurt when they're exerting themselves. But one of the key ways of differentiating between these diseases is that usually patients who have like a neurogenic claudication due to like a spinal stenosis will have low back pain, and it's postural. That's one of the key things. So their pain usually increases if they extend, and then it decreases if they flex. The other thing is because you're compressing nerve roots that actually are important for picking up sensory information, go to the spinal cord, and then generating a reflex. If you're compressing on those nerve roots, they may have decreased or potentially absent deep tendon reflexes. But then the other important thing is because if these patients are a perfectly healthy individual with no plaques within their vessels or emboli within their vessels, their pulses should be normal, they should have no bruits, and their skin findings should be all normal. They shouldn't have any thin skin, cold skin, thin nails, thin hair, thin skin, ulcers, gangrene, etc. They shouldn't have any reduced or absent pulses. They shouldn't have any kind of like bruits that you can auscultate or anything like that. So that's some of the big things of being able to differentiate neurogenic claudication from your vascular types of claudication. Okay, let's talk about treatment. All right, so when we talk about the treatment of peripheral artery disease, we have these in two categories, if you will. One is if you have like your non-acute / critical type of peripheral artery disease. They're not at the point where, okay, we have to amputate the leg, we have to revascularize this right now. In those situations where it's not super severe, where they have maybe intermittent claudication, they have some resting type of pain, they have some skin findings, but it's not at the point where we need to revascularize them immediately, then we can employ some other types of medical management. So what is that? First thing, one of the actual things that have been shown to be able to actually reduce problems, increase the actual quality of life is exercise. Believe it or not, that's one of the biggest things. But all the other things is reducing the atherosclerotic plaques. So what are the reasons for patients developing athero? High blood pressure, lower their blood pressure. High LDL, lower the LDL with statins. Glucose, having better glucose control with diet, exercise, insulin, anti-diabetic medications. Smoking cessation. And the other thing is potentially is if they have a thrombus, there's always a risk that you could rupture or fissure that actual lining there. And then on top of that, develop a acute clot on top of that actual plaque, and then cause a significant propagation of the actual plaque, causing a reduction of blood flow significantly. So sometimes in these patients, we consider things like aspirin or clopidogrel, also known as Plavix. So those are the situations we can consider, all right? Now, if we have a patient who we employ blood pressure control, lipid control, glycemic control, smoking cessation, maybe aspirin or clopidogrel, and then exercise, but they're still experiencing refractory symptoms, we can consider something called cilostazol. So this is usually refractory. We'll add on. This is an add-on in patients who are refractory to what we just talked about. So refractory to risk factor modification plus your antiplatelet medication such as aspirin or clopidogrel. One of the cool things about cilostazol is it's a vasodilator. So if you have a vasodilator, that's going to be able to open up the vessel a little bit more and help to be able to increase the perfusion past the area of that significant stenosis to get enough blood flow to the tissue. The other thing is that it's an antiplatelet, so it can act just like what? It can act just like aspirin or clopidogrel, so you get a little bit of an antiplatelet activity as well. So generally in these patients, we'll start them off by saying, let's exercise, smoking cessation, get your blood pressure under control, take a statin, control your diabetes, and then on top of that, exercise. Once we've done that, if they're still refractory, cilostazol because it's an extra antiplatelet as well as a vasodilator. And then to prevent thrombus propagation, aspirin or clopidogrel. Okay, we talked about these. Now, what if we have a patient who we've done everything, risk factor modification, vasodilators, they're still getting worse, or they're not getting any better, or we have a patient with an acute limb ischemia, the 6 Ps, or critical limb ischemia, they have ulcers, they have gangrene, they have terrible resting pain for more than 2 weeks, then what do? We're gonna talk about these now. All right, so for this situation here, if you have a patient with acute limb ischemia, they have an embolus. That's the most common cause, right? So if they have an embolus, you better be able to consider anticoagulating these patients. So usually we start off with heparin. So heparin would be kind of the first thing to go to. Then after that, we have to be able to get that clot out of there. So sometimes what we'll do is we'll have to do some type of maybe like a thrombectomy or a thromboembolectomy. So go down, snake a catheter down to the actual vessel, figure out where the actual embolus is, and then remove that. Or sometimes we can even shoot TPA into that area there. Okay, so generally we're gonna start them on heparin, and then we're gonna do some type of like removal of the embolus, whether that be catheter-directed thrombolysis with TPA, or whether it be removing the embolus via thromboembolectomy. Okay, so that's what we do with an acute limb ischemia. So if you have a patient with the 6 Ps, what is it? Pain, paralysis, if they have pallor, if they have poikilotherma, if they have paresthesias, and if they're pulseless. But it's important to remember, which ones would we do this for? They have to have a viable limb or a threatened limb. If they have a, again, non-viable limb, would revascularizing that benefit them? No, those patients need an amputation. So it has to be for an acute limb ischemia which is viable or threatened. The next thing is if you have a patient who has a viable acute limb ischemia, or they have a threatened acute limb ischemia, or they have a chronic or some type of issue of PAD that now they have a critical limb ischemia, okay? They have resting pain, maybe they got some ulcers, maybe they got a little bit of gangrene in those situations. If that happens, we can potentially employ an endovascular or surgical type of procedure. Now, for the endovascular procedures, what we would do in this situation here is we could put in potentially something like a stent. And what the stent will do is it'll allow for us to be able to get blood flow through this area here. So we're gonna actually sometimes do what's something called an angioplasty. So we'll put in a stent and we'll do something called an angioplasty. So what we'll do is we'll balloon open the vessel to push down the actual thrombus or the plaque, and then put a stent in there to maintain a patent blood flow through that. And sometimes if you put in a stent, just remember you may require dual antiplatelet therapy for at least 1 year, and then you can go into something like aspirin by itself afterwards. The other option here is something like surgical. So in this situation here, what we can do is we can actually put in a graft. So we can actually take, and if we have a very severe, like usually this is like aortoiliac. So we're doing surgical procedures where we're actually gonna put in like a graft if they have like a significant aortoiliac type of plaque. In that situation, having a bypass graft where blood can actually move through this area, this graft, and then maintain blood flow through the distal extremities, because we're not able to get it through this actual big plaque here. The other thing we can do is we can actually cut out the plaque, get rid of the entire plaque itself and cut it out. And we can do that via an end arterectomy. But these are the two types of actual procedures we can do. We can do either a graft as a bypass, or we can cut the actual plaque out via an endarterectomy. And again, if we need to in more of the mild cases, we can do a stent with an angioplasty. So balloon it, put them on dual antiplatelets, and then switch them to one of those actual antiplatelets long term. Okay, the other thing that I need you guys to remember here is sometimes maybe asked, it might be more something that we talk about later in future videos, something called compartment syndrome. But if you have like a terrible fracture, let's say, and you have a lot of actual compression, a lot of blood, a lot of areas that are compressing onto the artery that are supplying the actual distal extremities. You're compressing that because of high pressure with inside of these actual compartments. Maybe it's from a fracture. Maybe it's because you actually have something going on here, like massive rhabdo. Whatever it is, and you're compressing onto the vessel, the only way that you can actually prevent this is not just, considering heparin or thromboembolectomy, because there's no clot there. In this situation, it's due to compression. So what we have to do is we actually have to cut the actual skin open and the fascia open to be able to relieve the pressure and prevent the compression of the vessel. And so sometimes we can do something called a fasciotomy. But that would be in situations of acute limb ischemia, which is not due to an embolus or due to a thrombus. It's due to some type of compression that we talked about before, like from trauma. All right, the last situation is we have to cut the leg off, unfortunately. What type of situations would we do this? Well, first off, what kind of amputations are there? We can do an amputation with respect to the knee. So here's your knee. If it's above the knee, it's called a it's AKA, above the knee amputation. So if it's above the knee, that's an AKA. If it's below the knee, it is a BKA, a below the knee amputation. So in these situations, why would we do an above the knee or below the knee amputation? And we would do this because you have gangrene. So if you have like a very, very severe, particularly wet gangrene, because now you're at risk of sepsis. We do not want that limb to become super infected and you become septic. So whenever you see wet gangrene, you probably need to go ahead and cut the limb off. The tissue is not viable at this point. Or they have an acute limb ischemia that is non-viable, or they have a critical limb ischemia that is non-viable. In these situations here, you cut the limb, unfortunately. So that would be what we would talk about for peripheral artery disease. Now let's put all this stuff to practice and do some cases. All right, guys, let's do a case. So we got first case here, 74-year-old male presents to the primary care clinic for follow-up on calf pain. Patient states that his right calf pain has been occurring for the past 2 years and would worsen when he would walk around outside. However, recently He has been complaining that he's getting the right calf pain just sitting at rest in his chair. Past medical history is pertinent for hypertension, hyperlipidemia, diabetes type 2, and tobacco use. So he's definitely having some like vascular claudication types of symptoms here in his right calf. He has a lot of the risk factors for atherosclerotic plaques, hypertension, hyperlipidemia, diabetes, and tobacco use, and old age. So he doesn't have any stents, telling me that it's unlikely kind of a stent thrombosis. And could it be embolus? Unlikely, since those are usually more of an acute cause. It doesn't mention if he has any history of AFib, any abdominal aortic aneurysms or popliteal aneurysms. However, that doesn't mean that it's not possible. And then unlikely to be really a vascularity of any kind. So I think this is more likely atherosclerotic as his cause, and I think that that's probably causing a reduced perfusion to his tissues, and he's developing ischemia. We just don't want him to get to the point of where he's infarcting. But I think the question is whenever you're describing the type of pain that he's having, what are the types of PAD pain is really important. Is it intermittent claudication? So how do we define intermittent claudication? It gets worse whenever you're exerting yourself because your demand goes up and the supply is already low. So he would have pain whenever he's exerting himself, and then it would be improved when he rests. Well, it seems like that used to be the case, about 2 years, but for the past 2 years. However, now it doesn't seem like it's more intermittent. It's happening when he's sitting at rest, telling me it's a resting type of pain. So resting pain usually is just pain at rest, but it changes with positions of the leg. So if you elevate the leg, now you're having blood flow move against gravity. That's going to worsen the pain and then cause a decrease in color. The foot will become a little bit more pale. If you have them hang their legs off, where blood flow is moving with gravity, then you'll have a little bit more perfusion going down to the actual leg. And so the pain will be a little bit reduced and the color will be a little bit more ruberous. So you'll have a little bit more hue to the skin. And it's also called Berger's sign, right? Whenever you have a change in the color of the actual extremity, depending upon the leg position. And the last one would be type of critical limb ischemia, where they have resting pain for more than 2 weeks. They have ulcers, they have dry gangrene, they have wet gangrene. In those situations, I'd be a little bit more concerned. So I think intermittent claudication, he used to have that, but it sounds like he has resting pain now. And I don't think he has critical limb ischemia just yet. I haven't examined his actual skin, and it doesn't say how long he's been having the resting pain just yet. But I think as we elaborate a little bit more, he said that it's actually not been more than 2 weeks as of yet. But let's see if there's anything else that's kind of pointing off as what's going on with this guy. All right, so he does definitely have resting pain. I can definitely approve of that. And the next thing is, where is the actual pain subsequently resulting from which vessel being plaqued up or occluded? So if you guys remember, if it was the aortoiliac that caused hip, buttock pain, that also could cause reduced pedal pulses, popliteal pulses, femoral pulses, and it also could cause ED or impotence. That was called Leriche syndrome, if you guys remember. Okay, if it was the femoral popliteal, that causes calf pain, and if it was the tibial ulnar, that causes foot pain. His is in his calf. So what do you think it is? Femoral popliteal, my friends. Okay. Next thing we have to think about is, okay, other physical exam findings. Is there any kind of decreasing pulses? Is there any bruits that are heard? Well, he definitely has a diminished right pedal pulse and right popliteal pulse. Is this an acute limb ischemia is the other question. We didn't really mention if it was a critical limb ischemia, just because he didn't have any ulcers that we've been able to pick up yet. And he doesn't have any gangrene that we've been able to pick up yet. And the resting pain hasn't been greater than 2 weeks. So I don't think it's critical limb ischemia just yet. Is it an acute limb ischemia? Did he acutely start to develop pain, paralysis, pulselessness, pallor, any types of poikilotherma, paresthesias, anything like that? Well, he has a diminished right pulse. But the other things that we would have to say is, does he have any of the other things? So in this situation here, I don't really think he does have any of the other findings of particularly like poikilotherma, paralysis, paresthesias, any types of, he actually has a little bit of a pulse, so he doesn't have pulselessness. So I don't think he's fitting the true 6 Ps of acute limb ischemia. But the other things that we have to remember here is look at the skin, okay, because that's going to tell us if he truly may have a critical limb ischemia here. So, do you guys remember the progression of the skin findings in PAD? It always starts off with decreased perfusion causes them to be pale skin, cold, thin hair, thin nails. Those were the big things that we said, right? Then you start to see those punched out arterial ulcers over kind of like the more pressure point areas, so over the bony surfaces, maybe over the lateral malleolus. Usually they're going to be very clean cut types of ulcers. They're not going to be exudative or edematous and anything like that. So I think arterial ulcers in this situation would be a really bad one. And then dry gangrene. So do they have black discoloration but no exudative purulent type of appearance? Or wet gangrene where they're having exudative type of like purulent appearance, a lot of redness around the black discoloration and discharge. Then you start be thinking about wet gangrene. So in this situation, he does not have the 6 Ps, and we haven't found any types of wet gangrene, dry gangrene, or arterial ulcer. So I don't think he has a type of critical limb ischemia just yet. All right, so the thing that we have to go on to next thing to determine is, okay, let's get the ABI. If we look at the ABI here, we know that the ABI is basically the ankle systolic blood pressure over the lower, brachial systolic blood pressure, and that kind of gives us a particular number. If it's less than 0.9, that's abnormal. As we get lower and lower and lower, the more severe the PAD is. In this case, his is 0.5. He's got some pretty bad PAD. What's the next test that we could do, though? We could do a CTA with runoff to see if we can find where the area of the stenosis is, and it seems to be around that femoral popliteal region. And then if we wanted to, we could even do a duplex ultrasound, and he would definitely have like some high velocities around the area of the stenosis. And if we wanted to, we could even do a digital subtraction angiogram, very invasive, but definitely would be the gold standard. And it would show me that there would kind of be very, very little contrast passing through that area of stenosis of the femoral popliteal vessel. So he's definitely got some pretty bad PAD here. I would say that his is pretty severe. The next thing here is risk factors. So we have to be able to treat those risk factors. So his underlying cause is hypertension, hyperlipidemia, diabetes, and tobacco use. Controls BP. ACE inhibitors, ARBs aren't a bad thing for him. Statins would be a good thing for the hyperlipidemia. Smoking cessation is important, getting better glucose control, exercise, weight loss, and again, likely going to have to consider some type of antiplatelet for this gentleman. So aspirin would be an important one as well. Okay. Now, let's say that he's refractive to all of these types of measures here. What would be the next thing that we could add? What is the drug that's an antiplatelet and a vasodilator? Cilostazol. So that would be a cool one for that one. And if he's still refractive to all of the above measures, then we can actually go in there and fix this. So we could either do it endovascularly, where we go into where the stenosis is and put in a stent, or you could surgically fix it, where you actually go in and cut the plaque out with an endarterectomy, or you can do other particular things here, maybe like a bypass if it was really, really necessary. Okay, so these are the options that you have for this person. Now, let's say that for whatever reason, he started to develop a clot on top of that already plaqued like thrombus he has. The blood flow to the actual limb becomes so diminished that he starts to have severe, types of ischemia there, to where he starts to have no pain. He's paralyzed below the actual knee now. He can't move those muscles. He has like sensory losses now. He has so no sensations are able to be felt. He has a cold leg, no pulses. His leg is no longer non-viable. In those situations, you got to amputate. It would be likely either a BKA or an AKA in this situation. And then the other thing is, if he had any signs of like gangrene, whether it be wet gangrene that are maybe kind of progressing to sepsis in that kind of situation, you would definitely need to amputate the leg as well. And so in these situations, that would be the progression of the disease treatment. But Ninjas, I hope that made sense. I hope that you guys enjoyed it. And as always, until next time.